There we go. Okay. This is where we're going to start taping anatomy of the female reproductive system. Okay, is it definitely working now? The video camera, great. Okay, so let's go over the structure of female anatomy. I'm sorry, an alarm just went off in my house. I'm sure it's fine. I'll tell you on the break what it is. That's hysterical. Okay, all right, sorry about that. Okay, so this would be as if we're looking, it's a funny story, but I don't want to videotape, at the female anatomy. Okay, from the front. So the ovaries are where we create what are called oocytes. And we're going to go through oocytes and what they are and how they develop in a little bit. They'll be created in the ovary, and the ovary is actually attached to the uterus by a ligament. This is not where the eggs go through, right? The eggs will be caught by the fimbria. Does this all sound familiar? You did this probably in high school, right? And then the fimbriae take them into the uterine tube, which used to be known as the fallopian tube. And then the fallopian tube takes the oocyte into the uterus. If it is fertilized in the fallopian tube, and I'll talk to you about those steps in just a little bit, it will then embed into the inner lining of the uterus. If it is not, it'll come out in menses or menstruation. So we're going to go through all these steps. I'm kind of just giving you like a once-over. All right? Now, I'm sorry, excuse me. You will definitely need to know the parts of the uterine tube. So, all the parts here. Okay. So the fimbriae are the fingers. The infundibulum is the first widened part, almost like a trumpet that comes in. The ampulla is the curved part. And then the isthmus is as we get into and close to the uterine wall. You'll need to know those three parts of it. Okay? The uterus has an opening, but it's a pretty thick muscular structure. Okay? And then the tip of the uterus is the cervix. So the cervix isn't like really a separate structure per se, it's the tip. And it's a pretty narrow opening in the center of the cervix. And as a woman gets close to delivery, what happens to that cervix is it will thin. Okay, it'll thin right down and it will start to open. In a woman who is not giving labor and or pregnant, you don't want this canal wide open because infectious agents could come in and or the baby could come out. That's part of the problems with women. Some women, this will not have, there's also a plug that goes in there when a woman is pregnant. Sometimes that plug will come out, and as the baby gets bigger, this starts to thin, so the baby can start to crown and come out, per se, okay? Not crown necessarily like coming through the vagina, but, you know, start to push the cervix down, okay? So we want to keep that canal intact until birth, and you want to keep what's called the cervical plug or the mucus plug in there. Okay. There's different layers to the wall of the uterus. The endometrium is the inner lining. Okay, and that's made up of cells, as you could guess. Okay. The myometrium is the muscle. Can you guys read that in the back? Can you read those words? Okay. And then the perimetrium is the outside, and that's actually part of the serous membranes that we've talked about over and over and over again. Okay. And that melds into a serous membrane that, if you imagine the uterus, okay, we actually have serous membranes which come down and over that uterus. And then the double edges go to the abdominal wall. So what that does is helps to anchor the uterus in place. It needs to be held in a specific position. So those serous membranes, once again, help to create subunits, but it helps to anchor your uterus and your ovaries in place. Does that make sense? Okay, and I'll talk about that placement in a little bit. Okay, and that's called the mesometrium. Well, I would just know that ligament that I just mentioned, you can just call it the broad ligament. That's how it's commonly referenced. Okay, because it's a really big, broad ligament that helps to hold the ovaries, the fallopian tube, and the uterus in place. Okay? We'll talk about that in a little bit. Okay, so that's a good start. We're going to go over several of these in addition to this. Okay, here it is from the side view. So we have the rectum, we have the vagina, and then we have the urethra. Urinary bladder is here. Notice the placement of the uterus. The uterus is tilted forward. So this would be as if the female was facing this way. That is the common placement of the uterus. There are some women where it's tilted back. I'm going to go into this in the notes, so just listen, okay? The problem with that is that they have difficulty getting pregnant because of the placement of the uterus. Okay, with conception, if the uterus is tilted forward, it's just easier for a sperm to get in there, okay, and get up into the fallopian tubes to get to the oocytes. Okay, if it's tilted back, it's more difficult. It's also more difficult to keep the child, I believe, with the tilted back uterus. Okay. Do I go into? Just a second. Oh, I do. Okay. Okay. You can see, remember I told you, I showed you the paper going down over the uterus? You can sort of see, let me try to turn all the lights off. I think it's a little, maybe easier to see. Okay. You can see those serous membranes here. Okay, and then they go back against the wall. And what that does is it actually forms a little pouch, doesn't it, behind the uterus. If a female gets a peritonitis or an inflammation in their abdomen, it can actually, that fluid can settle into that area, okay? The other thing, with the placement of the uterus over the bladder, just so you know, because I don't think any of you have had children yet, right? I think all my moms aren't here today. It's okay. It's okay. They're probably studying for their lab exam. As your uterus starts to grow, guess what it pushes on? Oh yeah. Okay, so that's why a female who is pregnant has difficulty holding her urine. It's simply a space thing. As your uterus starts to grow as a pregnant female, it goes from your pubic bone all the way up to your xiphoid. And what happens is it just starts to push all the organs aside. That's why females have difficulty with your face is so funny as I'm going through these things. Everybody is though. We're just like, really? Right? You know, trouble defecating sometimes, just things are pushed aside, okay? It's well worth it though, I guarantee you. The vortices I'll talk to you about a little bit. Okay. So, with I have this labeled. If we look at one ovary, so that's what this picture of is here. Can you see the writing? Or no? Sort of? Kind of, sort of? Okay, so tunica albuginea is going to be the layer that is around this ovary, okay? Okay. It surrounds the cortex, And in the cortex, we have so tunica albuginea is the layer around the ovary itself. The cortex would once again be the outside of the ovary, okay? And the outside of the ovary is where the oocytes are. Are you with me? That's where they are. They used to say that females were born with all of their eggs. And they have found that not to be true. So often with research, as we get better at it and more progressive, we find different things. There's actually some cases where they can find little stem cells that can create new oocytes. But this is why they said, or used to say, a female shouldn't get pregnant later in life just because your eggs start to get old. They aren't as good, you know, unfortunately. Now the medulla is going to be where the blood supply is for the ovary. Obviously, it's got to have a good blood supply to keep these eggs healthy and nourished as long as possible. Okay. So as we start to look at the ovaries in lab, you'll look for different stages of maturation in these oocytes. Okay. And an immature egg is primordial. And we'll look at that, like I said, in lab. And it looks very immature. It just looks like a fuzzy little egg, and there's one layer of squamous cells around it. The other thing about that is that you'll see a lot of them. There's going to be just tons of them. Okay. Primary is an oocyte that's starting to mature. It's the lucky egg. It's been chosen to mature that month, to be ovulated. And what it does is it starts to get one or more layers of granulosa cells. They start to look cuboidal. So instead of, and this is hard to see, but like I said, we'll look at these in lab. You'll see they start to get bigger and they have more organized, cuboidal. And don't forget, cuboidal, as I've taught you, they're not perfect cubes, but they're higher and wider than the squamous cells. And they'll start to go around that oocyte. The next step is called a secondary. Now this is a little tricky because secondary could be also vesicular graphian, but vesicular and graphian are just a little more mature. So you would call a really early one, well, let me explain the difference. So a secondary follicle, an early one, has what's called an antrum. So let me draw that for you as much as I can. I make no promises with my drawing. Okay, so I don't know. Okay, so primordial, really thin layer of cells, and it looks like a little fuzzy egg. Okay, primary, you start to get more cube-shaped cells that just are thicker and bigger than those squamous cells. And you may have, 2 layers or so, okay? All the way around it. Now, moving on to secondary. With secondary, what happens is you start to get what's called an antrum. And an antrum is a fluid-filled space. Gosh, I don't know. I'm such a bad drawer. I don't know if this is going to help or hurt you, to be honest with you. If you could see it on the picture, this is a better representation. Can you see that on the picture? I thought I was going to be able to draw it for you better. Maybe we should go with the picture. Okay, you get more of those cuboidal cells, and you've got the oocyte right in the center. You've got a fluid-filled antrum, and then you get more of those cuboidal-shaped cells starting to surround it. Okay, a late secondary, which is also known as vesicular or graphian, starts to move that egg almost out on a stalk of cells. See how this antrum's really big and it forms like a C shape around it? Excuse me. and there's a stalk of cells there, and you still have those granular cells or those cuboidal cells around it. Okay? That's getting ready to come out when it's at that point. Okay? When you look at the slides in lab, you'll probably see many of these late ones. That's because I think they pump them full of hormones. We are not going to pop, 5 to 10 eggs out at a time. We might do a couple. That's where you get twins or triplets or whatnot. Okay? But I'm pretty sure that the ovaries that we look at, much like a woman who has multiple births after going through treatments, has multiple children, you'll see on the ovaries there'll be multiple that are mature. Okay? That's not normal, right? Or we'd all have 5 to 10 babies at a time. Right? After having one's good, right? At a time. All right, so does that make sense in the maturation? Now the other thing about this picture that I want to clarify is the egg doesn't move, right? They're showing you the maturation at different places. It stays in one place and it matures. Some people, maybe that's obvious, but I've had some students ask me that. Stays in one place, it matures, and then it'll be ovulated.
So basically just projected out, because I know in
Yeah.
like high school it was more or less, they were like, oh, it's pushed into the tube, but it's not.
It's kind of not, because that's what the fimbriae do. The fimbriae, I've actually watched videos of it, will kind of like, ooh, come here, egg. You know what I mean? Yeah. And so, I think for the most part, it's going to go up that way anyway. I don't know if it's necessarily pushed into the tube or not. I always had the impression the fimbriae kind of like brought it in. It's probably a little bit of both, honestly. Okay. Now, after it's ovulated, there is, I think I talked to you about this later, there's a little layer around, it's almost like a membrane, around the oocyte itself called the zona pellucida. We're going to talk about this in pregnancy, okay? And then theca folliculi, I'll talk to you about that in pregnancy as well. There are some cells that just stay on that oocytes when it's ovulated. Those little cuboidal granular cells, some of those will stay with egg as it is ovulated and comes out, okay? Now, it comes out and there is scar tissue left called the corpus luteum, okay? And the reason that that is important, the corpus luteum, is if there is conception and the baby embeds on the inner lining of the uterus, the corpus luteum will release hormones that help the baby to stay viable until it has enough of a placenta to release hormones. The placenta actually is an organ that will release hormones that keeps pregnancy viable. Okay, we'll get into those hormones in the future. If there is not conception, this will turn into scar tissue, okay, called the corpus albicans. Alba means white. Okay, you have, if you were to take my ovary out and look at it, I'd have a whole bunch of those albicans, corpus albicans on it, because I have ovulated more times than you guys, because I'm obviously twice your age, or more-ish, sort of, right? I don't like to think about it. So, okay, it leaves a little scar tissue, and also the surface of it will be scarred as well, because that's where they come out, okay? That's a lot. I gave you a lot on this little slide. It's so fascinating and interesting. Do you have any questions about it?
So is that why menopause happens?
Because you get old like me? Is that where you're going? I'm teasing you. Menopause is just a natural occurrence that happens with age. Yeah. So it has nothing to do with the scar tissue.
So you would have to basically cut into the ovary to be able to see the white.
Yeah.
Right?
Yeah. You would know on the surface. There's scars on the surface, but that actual structure is in the cortex of the ovary. But I guarantee you, you'd be able to know where they were because you would see a little scar on the surface, right? Are you with me?
Yeah.
Yeah. I don't think the scar on the surface, and that would be
So you can't see it with the
microscopic.
naked eye.
Well, I think you'd probably need at least a dissecting microscope to see that.
Okay.
Yeah. I studied, I teach pathophys for the nurse practitioner program here. I'm getting prepared for it. I listened to, his name escapes me right now. But anyway, he said that, and he was a medical doctor for years and did dissections and cadavers and whatnot. He said he could find every scar you've ever had, including bug bites, because it leaves scar tissue behind, so. And then your body's going to try to fix that, but it doesn't fix it as well as the original tissue. So it leaves behind that scar tissue, which I feel fascinating. So, good. Any other questions? All right, moving on. So corpus luteum, I do want you to know that, right? So that will be the structure that releases hormones if a woman becomes pregnant. And we'll get into the hormones a little bit later. Okay, corpus luteum. If a woman does not become pregnant, this turns into scar tissue. Okay? And it'll eventually turn into scar tissue either way, but I mean immediately. Okay. We good? I think I hit, so ovulation, we know what that is, right? When the oocyte comes out. Questions? No. All right. Okay. And we'll go through this series of dates and times from conception to delivery. But what happens is we conceive in the, I'm going to say fallopian tubes. Realize your book says uterine tubes. I just learned it as fallopian. That's how it is for me. It's the same thing. Okay. You probably learned it as fallopian. Okay, good. So conception happens in the fallopian tube at a very specific time. And then the egg starts to mature. Well, the baby really starts to mature. And it'll come down and embed into the upper lining of the inside of the uterus, okay? That's what happens with normal conception. Unfortunately, sometimes, I don't know why, it will stop in the fallopian tube. Or there's been times we spoke about the fimbriae trying to get the egg. Sometimes it'll sneak out that opening between the ovaries. I mean, very, very rare, and it can embed in the abdomen, but that's very rare. Yeah, I know. Where it usually goes wrong, how many of you do not want to have children after I started talking about this? Okay, good, I haven't scared you yet. Rock on, here we go. Okay, so what can happen is it can embed in the fallopian tube. It's very, very, very bad. If you know a pregnant female who is starting to have bleeding, vaginal bleeding, bing, 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 that sign, and or extreme abdominal pain, especially early in the pregnancy, they need to be checked. Because, I mean, the fallopian tube, you understand, is small. The opening, you understand, is like a hair's width, right? So if it embeds or stops in the fallopian tube, it'll start to expand that tube. If that continues, it can break open. So that is called an ectopic pregnancy. So common signs are what again? Pain, severe pain. Like, has anybody ever had appendicitis? Yeah, like that pain, you're like, wow, something's really wrong, right? Like, in your hind caveman brain, you're like, I need something done, right? That kind of pain, right? And also vaginal bleeding.
Don't they remove the fallopian tube in those cases?
With an ectopic pregnancy? Oh yeah, I don't think they'd be able to keep that. I would guess though, I mean, this is not my specialty, I would guess with the other fallopian tube though, if they could stabilize the uterus, that female could probably still become pregnant. But I'm totally guessing, right?
My stepmom had an ectopic pregnancy. pregnancy.
Oh.
She actually didn't even know she was pregnant. She thought she was just having like appendicitis or like constipation or anything.
Oh, is
So
she
went to the
okay?
hospital. Yeah, she was told she can't have children after.
She was, okay.
They said it's not really that she can't, but that it's like too high of a risk.
I was wondering about that, just like VBACs, you know, where they can't have vaginal births after C-section. I was wondering about that, so thank you for telling me that. So you could not have children after
Once you
this.
have one C-section, you can't have a vaginal birth.
There's mixed opinions on that. Some people say you can, but the risk is that you can break open that scar tissue. I wouldn't, I mean, especially after giving birth to a child without medication, yeah, let's do the C-section. You know what I mean? It is no fun, believe me. When you go to have children, who wants to have children in here? You start asking the minute you walk in the front door to the receptionist, where's the anesthesiologist? And then every 5 minutes after that, you ask your nurse, where's the anesthesiologist? Don't miss the window. But anyway, so there's mixed opinions with that. So, yeah, you don't. I mean, my first child, I had it. It was beautiful. I actually told my husband I was in love with the nurse anesthetist. He goes, no, you're in love with me. I'm like, yeah, no, I'm in love with him right now. I love you with all my heart. But it's just unbelievable. So, anyway, yeah, we had a question.
Isn't it like if you have a C-section that you cut like part of the muscle so you can't like contract as well? Isn't that why they
Yeah.
you can't do it either?
I think, well, that's part of it, but really they're afraid, I think, that it's gonna rip, you know? So I can't imagine it would be easy to do either. So, yeah. Any questions? No? All right. Okay, so moving on. Pelvic inflammatory disease, and I have you do the STD lecture at home. Has anybody done the STD lecture? Do you see why I have you do it at home? Okay. So that actually takes up the place of like a lecture, the STD one, and you have a short quiz on it as well. And that's, you know, if you want to download those PowerPoints, I think those are good things for you to do. But pelvic inflammatory disease can just happen from bacteria coming up the cervix. So lower abdomen pain, fever, rapid pulse, chills, back pain, pain during sex, vaginal discharge. And there's different bacteria that can do that, which I have in the STD lecture, so make sure that you watch that. Okay? In order to completely know what it is, they would have to test it and see what type of bacteria caused it. Okay? So here's the different placements of the uterus. Okay? And remember I talked to you about the broad ligament. I feel like it's really hard to see this today. Is there any way we could put the light up on the, I don't think, right?
It's burning out.
Does it look dark to you guys too, or is it just me? It's just me. All right.
Yeah.
It looks different, doesn't it, today? All right. Anyway, so different placements of the uterus. I spoke to, well, that's a bit better. Okay. The mesometrium, you can just say, that helped, didn't it? Switch the lights. As a broad ligament. Okay, just remember that. That's that serous membrane that wraps around it like a piece of paper. God bless you. There's also something called the round ligament. That's more like what you would picture as a ligament. It comes from the top of the uterus and it actually goes all the way down to the labia majora, which are the lips, the vaginal opening. Those also help to hold it in that forward position. Okay? And that is called anteverted, A-N-T-E-verted, okay, right here. Okay? Now, with a female, I mean, we're just born this way. If you have one, retroverted is tilted back, retroflex is tilted back and flexed backwards. Females with a uterus that is retroverted will have more difficulty getting pregnant. It's not impossible, I don't know about retroflexed, but I know definitely with retroverted, I have a friend who had it, and she was able to get pregnant, okay? So it's not that it's completely impossible, I just think it's more difficult to get pregnant with it, okay? So we talked about those anatomical structures, and we looked at that cervical canal. And remember, the cervix is the tip of the uterus, okay? And it will thin as a woman gets closer to delivering, okay? And you notice that little canal that we were looking at, we'll look at that in lab as well. When a female gets pregnant, actually, we always, when we go through our cycle, create what's called a mucus plug. Okay, as we get halfway through our cycle and we ovulate, a mucus plug is created, okay? In a non-pregnant female, it's obviously just very small because you've probably never noticed it before. In a woman who becomes pregnant, it will thicken. So it helps to close off that opening, okay? When your water breaks and you get close to delivering, I know, it sounds gross, you lose that cervical or that mucus plug, okay? Some people find it's very obvious, that's a sure sign, other than the contractions, that you're probably gonna give birth. Some people don't notice it at all, okay? Depends, from female to female, okay? So, any questions on that? Good. Go to. You know, adventitia is the area that doesn't have those serous membranes on it. And the outer layer, okay? Muscularis is the muscular portion, and then the mucosa is the inner portion. I think it's better to remember as endometrium, myometrium, and parametrium, okay, and then that broad ligament. So these are basically different words for the layers. The outer layer would be adventitia, muscularis would be the muscular portion, mucosa is the inner portion. I think it would be more clinically important for you to remember endometrium, myometrium, and parametrium, okay? The parametrium is basically the same thing as that broad ligament, okay? There are also what are called fornices. There's a posterior, so if we turn off the light again, okay? Posterior, so here's the uterus, right? Here's the cervix, which is the tip of the uterus as it goes into the vagina. Here's the posterior fornix, here's the anterior fornix. So it's basically that space that's in front of or behind the cervix. This is an area I talk about with the, I think it's on the next slide actually. Yeah, we'll do this slide and then we'll take a break. Back before abortions were legal, women used to try to self-abort with a hanger. Have you ever heard of that before? I know, I hate talking about it, but you may see it. And the problem with that is that anteverted, right? So if you think about it, if they put a hanger in there to try to get the, oh, it's just so disgusting, child out, they're not gonna have the right angle. So what happens is they get this bacteria-laden hanger and put it into their posterior fornix, and guess where that goes? Into the peritoneum, right? So they would introduce all sorts of infectious agents into their peritoneum. It's kind of scary stuff. So anyway, I do believe they could also tap fluid if somebody has a severe peritonitis. I think they can do that. Vaginally, don't take my word on that. I think it's just something that's in the back of my head. Okay? All right, so that is a good start. Let's take a quick break and we'll move on to the next part. Any questions? This is always the page that I turn to if I'm studying at the gym. So I'll be like, whatever I'm studying, like yes, I study with my A&P book at the gym, and no matter what, I turn to this page. I'll be like, flip, 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 yeah, you know. I'm looking for endocrine, I flip to this page. I'm looking for skeletal, I flip to this page. I'm like, really? You know, where the choice is. But this is something that you will need to work with. If you're a nurse or a doctor, you'll have to do examinations and, right, catheterizations and whatnot. So, labia majora and labia minora are the lips. Majora have the hair. Minora do not, okay? They come together at the top, at the clitoris. Just underneath that is the urethral orifice. Some nurses will call it urethral meatus. Meatus is a different word for an opening. We talked about it with the ear canal, okay? So meatus, I think that they've moved more towards orifice, but just so you know, okay? Just below the urethral orifice or posterior to it is the vagina, okay? And the hymen will be skin that is ruptured or separated upon first intercourse. This can also happen with sports, okay, in a female. In the back, there's an opening for the greater vestibular gland, okay, back here. You don't have glands in your vagina, you have glands in the cervix, and you have these glands, okay, that help with intercourse. The reason it's important for you to know about these, they're also called Bartholin's glands. Sorry, I was trying to think. Let me look up the spelling for that one. Greater vestibular gland, hold on. Bartholin glands. Hold on. Let me make sure that's right. Yeah, it's Bartholins, Bartholin's glands. Because once again, you might hear somebody. The reason I'm going to point these out, other than the fact that they help with Bartholin, just like it sounds, Bartholin, L-A-N, okay? Other than helping with lubrication during intercourse, is these can get infected in a female, okay? And they can swell up. So the opening can get a little bit of bacteria or something into it, and a female can get swelling in that posterior opening of the vagina. Completely normal. It's usually self-correcting unless it gets really bad, okay? So just want to earmark that. Now, and then the anus obviously is going to be the most posterior opening. What is this area called? The perineum. And the reason that that is important as well for you to know is with childbirth, they can do a small incision on one side. The reason this is important is it will help to guide if you're going to rip it all during birth. Okay. There are some people who don't believe, are you learning new stuff today? Right? Who don't believe in doing this. They think you should rip naturally. Let me share a story. One of my friends was the coach for her friend. They're not a couple. She just was a single mom and she wanted to be there for her. She decided to go au naturel and not do the incision. It's called an episiotomy. I think I have it later in the notes. If not, I'll put it up on the board. She decided not to. What happened was she ripped right down the middle. So my advice to you is take the cut, okay? For future reference, it guides where you rip. And if you end up having huge, have any of you ever seen my husband? My husband is 6'4" and has a head that's probably twice the size of your head. So, you know, I'm telling you, as a mom of 2 humongous babies, get the episiotomy, okay? And I'm as natural as it comes. I mean, I don't like any medicines or whatnot, but anyway. So with the perineum, they could do that slight incision to guide that. TMI, right? You guys are like, this is just too much information. All right. So mammary glands are modified sweat glands. So will those be exocrine or endocrine? Exocrine, thank you. Okay. And in a lactating female, we will create milk in the lobules. Okay. They'll go through the lactiferous sinus and duct and out through the nipple. And we'll talk about the hormones that regulate that and why we don't lactate all the time in a little bit. Okay? As a matter of fact, if you ever find milk coming from your nipple, female or male, you need to get checked. What can that be a sign of? Cancer. Okay. So, if we go to the next slide, okay, which one would be lactating? All of these little, they call them alveoli in your book, I think. It might be called something else. But anyway, the lobules will be filled with milk in the little pockets, okay? They'll stay in the lobes until it's time to feed your child, and then you have what's called the let down reflex, which will let the milk come down to the nipple. We'll talk about those steps in a little bit, okay? Any questions about that? No? Okay. Breast cancer is everywhere, and make sure you do your screenings and keep up with your mammograms. I forget, when are you supposed to start mammograms?
I was like 30 years old.
Is it? Yeah, I was wondering that. When it, I mean,
40.
yeah, I know I've been doing them longer than that. They're no fun, but neither is breast cancer. So, and this, everything, if you think you have anything wrong, get it checked, because the earlier you find stuff, the higher the cure rates. Okay, so mammography is, where they compress the breast and take an x-ray of it. I know that seems weird because you're putting an x-ray through breast tissue, but it's very quick. It's probably less radiation than you get on an airplane flying through the air, okay? They're also doing MRIs. There's mixed reviews on that because they're so sensitive and they find everything. But that's how they found my mom's, is they used, I think it wasn't an MRI, it was a very sensitive mammography. And the nurse was like, oh, it's probably nothing, it was cancer. So go for sensitive, okay? Yes.
So I've heard of like it being dense and the x-ray like not being able to.
Fibrous tissue in there.
So do they go automatically to the MRI or do they just try an x-ray?
Probably if you have really fibrous breasts, I would think they would, to be careful. Because there are some people who get, little connective tissue packets in there.
Yeah.
It's harder to see if it's cancerous or not. So, now if they do find breast cancer, they can do a simple, what's called a lumpectomy, where they go in and the first thing they'll do is a biopsy and test that tissue, and then everybody's nodding, so this sounds familiar, right? And then a lumpectomy. If it has spread, they'll have to do a simple mastectomy. What that means is the breast tissue itself and a few lymph nodes. They'll test the lymph nodes to see if it has spread. If it is spread, then they have to be treated with chemo. A radical mastectomy, I don't hear of this as frequently as you used to, because I think we catch breast cancer so much earlier. But a radical here. So it would go lumpectomy, simple, and then radical. Radical means it has spread. So in addition to the breast tissue and the lymph nodes, they would have to take muscles, whatever surrounding structures it has spread to. But like I said, I think that's really, really rare that we see that at this point, because we catch it so much earlier. Thank God. Okay. Okay. So any questions about any of that? All right, cool. A second. Oh, wait, okay. Okay, so oogenesis is going to be the development of that chosen oocyte for that cycle, okay? And we went through those steps already, from primordial to Graafian, which would be mature. Graafian and vesicular mean the same thing from that previous slide. It's the later secondary oocyte, okay? We know that when it's released, it'll be ovulated, it goes into that fallopian tube to hopefully be, right, met by a sperm if the female wants to be pregnant. That sperm will then attach to that layer that I showed you that's around the egg and hopefully get in, okay? We'll go through that all in pregnancy. So with the ovarian cycle, it's approximately a 28-day cycle. It can vary from female to female. It can be slightly shorter, slightly longer. As you start to get closer to menopause, you'll start having fewer cycles as well, okay? Now, follicular phase and luteal phase, does that sound familiar? Yeah, what does it sound like that we studied a few weeks ago? Yeah, right, follicle stimulating hormone and luteinizing hormone, right? So we have the follicular phase, and on the next slide I'll show you. I think it's on the next slide. Yeah, those hormones. We'll talk about those hormones, okay? So if you don't remember that, we'll talk about it. The follicular phase will be when follicle stimulating hormone is helping that egg to go through the different phases that we spoke about. And luteal phase is when luteinizing hormone will start to peak, okay? And that'll continue if the woman gets pregnant. During that phase, we'll have more progesterone. What does it sound like? Gestation. What does gestation mean? Right, progestation. Okay, you've got to have the appropriate levels of, it's in the notes, we'll go through it a little bit, of progesterone, okay? And that luteinizing hormone will help that happen. Now, the progesterone will be released once again if a female gets pregnant from the corpus luteum, okay? Are you with me? Until the placenta is strong enough to help support that, okay? That baby. So here's I spoke to you briefly about the membranes and the granular cells. Let me just give you a visual because you'll need this when we get into pregnancy. So theca folliculi, don't worry so much about that. Zona pellucida is that membrane that's right around the egg itself that I spoke about earlier. I just noticed that I didn't realize I had put this in the notes itself. Okay, that's going to be the membrane that the sperm will have to get through in order to fertilize that oocyte. And when this egg is ovulated, it will release, well, not release, it still has some of those granular cells attached to it. And these granular cells are called corona radiata. Can you read that, or do you want me to spell it for you? Corona, like the beer, right? not that you drink. C-O-R-O-N-A, corona radiata. R-A-D-I-A-T-A, corona radiata. Somebody thought it looked like a radiating crown. And it's just the granular cells that the sperm will also have to get through to get into the oocyte. All right? Any questions? We good? All right. Let's see. Female hormones. Yay! Okay, great. Okay. So the hypothalamus, as you know, helps to regulate by releasing and inhibiting hormones, the hormones that we need for all these autonomic and automatic functions in our body. And it is kind of sensitive to the estrogen that's in the blood until we start to get into our menses, and then it just sets that 28-day cycle for us regardless, okay? And that'll actually help to regulate your hormones as well. Do you guys need me to go back and go over anything?
Yeah.
What do you need?
The corona radiata.
Yes, okay, let me back up. You guys can always wave your hand, I don't mind. So when it is ovulated, it takes some of those cuboidal granular cells with it, and they surround the oocyte, and then that is called the corona radiata. It's just the leftover cells from when it was still in the ovary, and then on it is that, did you need the zona pellucida too? Or did you have that already?
No.
No, you don't need it?
Yeah, I'm good with that.
You're good with that. Okay, yeah. So corona radiata, somebody thought it looked like a radiating crown of cells around it. Okay, so corona, C-O-R-O-N-A, radiata, R-A-D-I-A-T-A. Okay. Any other questions? Good? Okay, so okay. So the hypothalamus becomes less sensitive to circulating hormones and just says, this is going to be it. Here's our schedule. Okay, 28 days. And it doesn't kick right in 28 days immediately with a female. It takes a while to regulate itself, but it moves its way towards that. Okay, and releases that gonadotropal releasing hormone, which then releases follicle and luteinizing. Follicle stimulating, I should say. Right, and that's, I think, on the next slide. So a follicle always references sperm and oocytes, right? Definitely going, right? and helps that maturation of it going through all those steps from primordial to mature secondary. The second half will be luteinizing hormone, okay, until we menstruate. Estrogen levels decline, progesterone increases, preparing our body for potentially having a baby, right? Some females have a problem with their levels of progesterone, that's why they have to get the injections, right? Okay. I think I talked to you about HCG and pregnancy. Yeah. Okay, sorry, I was just trying to think of another hormone, but we'll talk about that in pregnancy. And that corpus luteum is going to release the progesterone until we either conceive, and then it stays viable until about the 4th month, releasing progesterone, or we don't conceive and we have our menses, okay? And then it'll start to shrink and turn into that scar tissue, corpus albicans. I think we've got that, right? Any questions on this? No? Where are these two hormones released from? Okay, thank you for remembering that. Good. All right, so there's layers. Okay, of cells on the inside of the endometrium. Okay, that is called, there's a basal layer and a functional layer. So you have a bottom layer that's always there. Can you imagine the inner lining of the endometrium? Okay, and I think we all know that obviously once a month that sheds off and we create a new layer on top of that. Okay, and there's different types of arteries that help to create these layers. The bottom layer that always stays there is the basal layer, okay? And that will create the functional layer, which ends up actually having a simple columnar on top of it. You don't need to know that, right? And blood vessels into that functional layer, and that builds over the month, and then towards the end of the month it will shed off. And then we rebuild that functional layer, and then it sheds off. So that's what's coming on and off, is that functional layer. Are you with me? Okay. So functional layer is shed during menstruation. Hormones are at the lowest. That's when we actually feel good for like 1 week of the month, right? And then the hormones kick in again. So days 6 to 14 is proliferative phase. We create that new functional layer. Estrogen is rising. Ovulation occurs at 14, day 14. Day 15 through 28 is secretory phase, although that's kind of confusing, isn't it? Because it should be, well anyway. I wouldn't ask you those. I would just ask you beginning or end of the cycle. Do you see what I'm saying? Because I think that's confusing. But anyway, prepare for implantation. Corpus luteum, secretes progesterone. Cervical plug is in place. Without implantation, the functional layer will begin to deteriorate. And what happens basically is the basal layer, the blood vessels to that functional layer will just get closed off. You lose its blood supply to that functional layer, it dies off. Comes off, then we rebuild it. Are you with me? Okay. Any questions on that? Good. That should all be common sense, I think, at this point. Well, not common sense, we've gone over it. Amenorrhea. So let's talk about this. Female athletes or anorexic. I'm talking about athletes who like really lose a lot of body fat, tend to have amenorrhea. What does A mean again? A means without. So why do you think this happens? This is, oh, I meant to throw that in the garbage. Why do you think this happens? This is important clinically to know.
Is it kind of like deprivation?
It is deprivation.
Even though the athletes are like strong, they still
Sure.
need more fat.
They need more fat. Why do they need more fat?
So they don't burn muscle?
So they don't, yeah, they don't burn muscle. In relation to a female getting her menstrual cycle, why would she stop? So you need to ovulate rising levels of estrogen. You ovulate, that starts to decline, and then towards the end of your cycle, right before you menstruate, your progesterone rises, right? So what do you think is missing in a female that is not getting her menses? Progesterone, or the proper levels of progesterone and the proper levels of estrogen. Does anybody know why? What are they made of? What are those hormones made of? Fat. They're made of cholesterol. You need cholesterol. You have protein-based hormones. You have cholesterol-based hormones, or fat-based, or steroid-based. All your sex hormones are cholesterol-based. And then the adrenocortical hormones are also fat-based. I want you to really remember these three, progesterone, testosterone, and estrogen are fat-based or cholesterol-based, steroid-based, okay? So you need enough fat to create those hormones so your body can go through these cycles. So females who don't have enough body fat and lose, I thought this was flipping up, that's why I was looking at it, and lose a lot of their fat, now don't have enough fat to create estrogen and progesterone. If they don't have enough, they won't have their cycle. Are you with me? Okay, that's bad. It's unhealthy to have that low body fat, but the architecture of your bones is created in your teenage years. Okay, you remodel them all the time, but the basic strength of them is created in your teenage years. And when you don't have your cycle and you don't have enough of those steroid hormones, estrogen is a huge supporter of bone health. You're not going to create that nice strong architecture with your bones. Are you with me? Does that make sense? Okay? So, not a good thing to have that low body fat, for sure. Okay? Does that make sense? No? Okay. Good. So, estrogen also helps with the maturation of your body. Your breasts will grow. You also grow width-wise. When I was you all know I was a chiropractor eons ago, and I would treat kids, and I would treat them usually from like early teenage, and I had several who I would just treat all the way, gosh, they're probably 30 now, whatever. And you could see once they went through puberty, their hips would widen, the bones widen, you just get bigger when you go through puberty, and you start to have those additional effects of estrogen and progesterone, okay? Now, estrogen levels also cause the epiphyses of bones, long bones, to close sooner. So what does that mean for a female? We're shorter, right? We don't have as much time to grow big, so we tend to be shorter than males, as a general rule. Okay. Any questions on that? All right. STDs, I just go through a couple, God bless you, a couple of, do you need? Good. Okay. So we'll go through a couple of these. I do want you to go through the lecture and take the quiz when you can on your own. It is in the next set of notes, I believe. Okay. I did put a little for your eyes only picture on there. It's not something you want to whip out if you're like studying in front of your small brothers and sisters. It shows everything, okay? But I think it's important for you to see everything. First of all, clinically, you're gonna see some crazy stuff. You're gonna see some crazy stuff that you think, how did you get here, right? So that's number one. Number two, for your own, I'm not gonna look at anybody because I don't wanna embarrass anybody, and I don't have anybody in mind, but for your own self-care, okay? Make sure you take care of yourselves, right? Use condoms and safe sex, please, because there's some nasty, nasty stuff out there. I'm not saying you should wait until you're married, right? But I'm being realistic, okay? So gonorrhea is bacterial, easily treated with antibiotics, I'm sorry, okay? Pain with sexual intercourse, and usually there's like a yellow or whitish or bloody discharge from the vagina, okay? So they'll actually test it because you can also get a yeast infection, which can mimic this, okay? So don't think if you ever have an issue that it's, you know, an STD, they'll test it and see, because it could be a yeast infection which would present similarly. Syphilis, let me ask you, let me riddle you this. Who is seeing an upsurge of syphilis?
The UK?
Oh, well, maybe, but that's not here. What population in our country? Nursing homes. I'm telling you, all my nurse practitioners, when I talked about this in class, was like, yep, I'm not making this up. Let's get it on. Oh, creepy. All right, so anyway, let me tell you what happens with syphilis, okay? Because it's a really, really weird presentation. And the sooner you can recognize this, guess what? It's highly treatable because it's what? A bacteria, right? So there's 3 phases. I don't think. Okay, so primary is there's what is called a chancre. And I think this is maybe in the STD presentation. If not, you should look this up, okay? That's the first thing up there, the chancre. So that's a first step. So there's 3 phases. The primary is the site of contact, where the bacteria comes in. Quite often you miss it, right? Because it might be vaginally, or it might be on the penis. They might notice it and be embarrassed and not want to show anybody. And it looks, you know, just like a sore, per se, okay? And the weird thing with syphilis is it heals, right? It goes away. It's not like herpes where you got it over and over again. So sore happens, point of contact, it goes away, okay? They're like, okay, great, whatever, it's gone, right? The second, okay, is pink rash all over your body, possibly fever, joint pain, okay? So it's almost like hives all over your body. And once again, you can look up, if I don't have it in that presentation online, you can look it up, okay? But the weird thing about that is, guess what? It goes away. So they think, oh, I just had an allergic reaction or something like that. If it's not treated, and they go through those 2 phases, and I forget the timeline, I'll be honest with you. I want to say years, but I'm not certain. They can move into tertiary syphilis. And what this does is it creates spots in your brain called gummas. And it basically destroys your brain tissue. And they start to lose their mind and kind of go crazy with these. And at that point, it is not treatable. Those gummas are permanent, okay? So you should know those steps, right? You should know those, because if you catch it in primary or secondary, you can treat it. By the time it gets to tertiary, it's too late.
Wasn't it like back before they had like antibiotics, like people's like they could lose their like noses and stuff from syphilis, like from the bacteria?
I haven't heard that, but I mean, maybe.
I don't know.
I'm not sure. I'll look it up. So I thought that was more internal at that point, but maybe.
Do they know why it goes to the brain?
I'm sure somebody who teaches this on a cellular level could tell you. It's got to be receptor related somehow, just like we talked about hormones. And hormones circulate and will latch onto a certain area. There's got to be some sort of affinity for it, and or weakness in the brain that lets it damage the brain. So, good questions today. All right, so syphilis, crazy disease. Chlamydia, chlamydia, gonorrhea, you have to test and see which one it is. Similar, right? Similar presentation. Pelvic inflammatory disease. With both of them, though, I don't think I mentioned, and I should, The problem is that the infection, if it continues, can come up through the uterus and into fallopian tubes. And if that happens, guess what? You can create scar tissue. That scar tissue then would not permit that female to be able to get pregnant. So this is something that you should get checked if you ever have this issue, okay? And make sure. Excuse me. Okay, HPV. The human papilloma virus, are you familiar with this? I think most people are because there is a vaccine for it now, right? There's many different strains, and this is a virus. So if you contract this, you have it permanently, and it can cause genital warts. Other than that being icky and having genital warts, it can cause cervical cancer. Okay, so that's why I think they were so hard trying to get that vaccine for females. I believe males can get it too
Yeah.
to help prevent it, but does it cause any cancer in males? Go ahead.
I don't know, but I saw on the news, I think it was either today or yesterday, that they're not like promoting the vaccine for guys, and that's a problem.
Oh, really?
But,
Yeah.
And then I was gonna ask,
Yes.
so does that encompass like
Who's
warts?
not promoting it? Because I know, yeah, it doesn't encompass
I
what.
think it was just talking about like doctors in the U.S. I don't know if it was specific, but does it encompass warts like on hands and feet?
No, I do think it's a similar virus though. I think they're different strains though. So I don't think that that can be transferred.
Okay.
But let me tell
That's
you
not
what can be. Any more questions about this one? Because this can be. Oral to genital. You can transfer 1 to 2. Does everybody get what I'm saying? Okay.
So one was transferred to 2.
Uh-huh.
Is it still
I think it's considered 2.
as 1? Okay.
I think it's
So
considered
just
2 because of the
considered 2
location.
Based on location.
Okay. I almost saw a couple split up because she thought he was cheating on her because he showed up with this. You can figure out the rest of the story. If you can't, come to my office. Okay? I saved a marriage by knowing this. Okay? So it is transferable. Okay. All right. So there's medicines you can take that I think help to keep the symptoms at bay. This is also why, I was never a germaphobe. None of us have herpes in my house, but I was never a germaphobe until I had kids. And I'm telling you, everybody has their own toothbrushes, everybody has their own toothpaste. Once you have kids and you have something raging go through your house once, you're like, that's it. You're gonna have your own stuff, you're gonna have your, I just don't share things with people is my point. Don't share bottles with people or toothpaste or anything because you just don't know, okay? My kids are like, you're such a germaphobe. I'm like, yeah, I am. So anyway, okay, so let me make a little correction here, please. Okay, so what's wrong with this slide? Let me ask you, because some of you already asked this. Yeah, it's 23 pairs or 46 chromosomes. I'm sorry about that. So correct that here, okay? Correct that there, please. Okay, so 23 pairs, 46 chromosomes, okay? So the sex chromosomes are the X and the Y. I think we know most of this, right? XX is female, XY is male, okay? And then the rest, I don't really go up. You do medical genetics, don't you? I believe. Nursing doesn't?
We do, yeah.
We just do genetics.
We do healthcare.
Healthcare genetics, okay. You don't go through the whole karyotype or, no? Okay, well, anyway, so I really don't go over it either. I just go over a couple of genetic abnormalities. So just for example, you could have a female born with Turner syndrome who has an X, but no second X, okay? The typical presentation for them is they have no ovaries, but they also tend to be short in stature. God bless you, I believe they have a webbed necking. right here, or webbing in their neck, I should say, okay? It just happens, right? If you look through the steps of development, when you go to have a child, if you become pregnant, go to a site called Baby Center, put in your email address, and you'll get updates every week. And you'll see just how complex it is for that baby to develop. It's unbelievable. And we'll go over some of the basic steps in here. But my point is, there's so many steps. It's amazing that things go right so often. Things just go wrong, okay? So Klinefelter's is a genetic abnormality seen in females. Klinefelter's is seen in males. They have an extra X. They tend to be sterile and a little bit more effeminate, okay? Supermale is XYY. High levels of testosterone, more aggressive. This is for real. And guess where we see this quite often? What population? Prison. Yeah. So, because they tend to be more aggressive males, right? They've gotten in trouble. So, and there's a million more things that can.
Isn't there a triple X?
Triple X? It sounds like a movie. No, I'm just kidding. I'm sure there could be. It's not my specialty with genetics. Did you learn that? And
Yeah, we talked about it in sociology.
oh,
Different.
I'm sure. Absolutely. It's kind of, oh, it's, yeah, it's amazing. Any other questions about that? No? Okay. Differentiation begins at week 7. Organ systems are developed and working at week 7. Like your nervous system is already very, elementary, but it's starting to work at week 7. It's amazing to me, okay? One example of developmental issues, there's a ton of things that can happen. Kidneys start low and go high. Oh, we'll actually go into this in pregnancy. I think I just gave you one example here. So one example you have to check with males when they're born is that their testes have descended. They actually begin in their abdomen just like our ovaries do, right? And our ovaries stay where they are when we get that XX, right? Males, they'll actually be guided by a fibrous cord called the gubernaculum down through the abdomen and into the scrotal sac. That needs to happen. If they stay up in the abdomen, that male can be sterile, okay? And they can do, I think, a very simple surgery to bring the testes down into the scrotal sac, okay? So that happens about the 7th month. The steps are just unbelievable with development. We talked about secondary sexual characteristics. Those will obviously kick into place at puberty, and that's when the sexual organs start to be functional. That makes sense. Menopause, estrogen levels decline. We start to lose that cycling through. It can happen anywhere between 46 and 54. A true definition will be 1 year without menstruation. We're not going to do the case study. We're just going to leave a little early for once, all right? So next week, don't forget you have your exam. I will see you at the appropriate time and place. Email me if you have any questions. Thank you, guys.